Hello, everyone. Thank you for joining us today for the 340B What You Need to Know webinar. If you take a look on your screen, you see a bar similar to this one that you see. What we want to do is we're going to be taking questions at the end of the webinar. But in the meantime, if you have questions, what you can do is you can submit your questions in the Q&A box. What will happen is a box will pop up and you'll be able to submit your questions that way. Or you can submit your questions in the chat box. And a chat box will pop up, and then we can take a look at your questions and we can answer them again at the end of the webinar. So moving right along, our first panelist we have today is Blake Hartgraves, Regional Health Systems Account Manager at Walgreens. Blake, I'm going to give you controls, and you're good to go.
Perfect. Thank you, Kenya. So as Kenya mentioned, I'm Blake Hartgraves. I work with Walgreens as an account manager with them. My responsibilities with Walgreens are to not only manage some of our currently existing 340B clients, but to also walk clients who want to be part of our 340B program through the contracting process and making sure that they understand the program. So I touch a little bit of both sides with our program, and that's what I do. So moving right along. Today, my plan is to talk with you all a little bit about a higher overview of 340B, kind of what it is, who's eligible, who can be part of the program, how do you become part of the program, and how does that relate to a contract pharmacy, and what do you want to be looking for with that contract pharmacy partner as you do a little bit more research and figure out more about the 340B program. So this first slide really, like I mentioned, is that high overview of the 340B program. So really the definition here is it's a federal program that requires manufacturers to sell drugs at reduced prices to eligible healthcare organizations, otherwise known as covered entities. So you'll hear that phrase a lot, a covered entity. Covered entity is that person who's registered and eligible for the 340B program. So hopefully that's all of you on the call today. That's you are all covered entities or potential covered entities. The purpose of the 340B program is it's to enable you, the covered entity, to stretch your scarce federal resources so you can reach more eligible patients and provide more comprehensive services. So I love to use a phrase here called increasing access. That's really the overview of the 340B program. It's to allow you, the organization, to increase access to your patients. So at Walgreens, when we refer to the money that you receive through the 340B program, which we'll get into later, we call those dollars increased access dollars in lieu of revenue, which is in a lot of cases considered kind of a dirty word in 340B, an all nonprofit organization. So instead of calling it revenue, we call it increased access dollars because that's the purpose of the program. It's for you to be increasing access to your patients. This program is administered by the Office of Pharmacy Affairs, which is a division of the Health Resources and Services Administration, otherwise known as HRSA. So you'll hear that group a lot as well as you dig into 340B. HRSA, they are this big kind of eye in the sky, ominous group that makes sure that not only administrates the program, but also makes sure that the covered entities who utilize it are utilizing it appropriately and are not abusing the program. So if you do become a 340B entity and you use contract pharmacies or have an in-house solution, something you want to make sure you do is you stay compliant to the rules of HRSA because they do audits of the covered entities, which could result in paying back money to manufacturers or even losing eligibility to the program altogether. So that's who administrates it, and that's who you want to make sure you're keeping happy as you're running through the program. An interesting blurb out here to the side. Participating covered entities report savings that range between 25 to 50% of average wholesale price for covered outpatient drugs as a result of 340B discounts. So sometimes they can even be more than 25 to 50%. There's a lot of drugs out there that are a penny after the 340B discount. That's the cost of the drug. So sometimes it can be extremely significant for the patient and for your organization, these types of discounts to the program. So moving along, nonprofit healthcare organizations. So these these are the organizations that are eligible for 340B. And again, they're nonprofit healthcare organizations generally, and they have certain federal designations, and they receive federal funding from specific federal programs. So health centers, hospitals, specialized clinics, Ryan White, HIV/AIDS programs, all can be eligible through 340B. Something that we'll cover later on is that if you are interested in knowing if you're eligible or how to sign up for 340B, my recommendation is that you contact a group called Apexis. They have a great answering line called Apexis Answers. That's who I would call if you're interested in knowing specifically about your organization on how you become eligible and how you register for this program. This gets into eligible patients and eligible drugs. Really the point in this slide and the next slide coming up here is not all patients, not all drugs, not all payers are going to be eligible through 340B. It becomes a little bit complicated at this part of the conversation because it's not just black and white. It's not, if I'm a patient that was seen at your facility, I'm eligible. There's other things to take into the conversation here. So eligible patients. An eligible patient is an individual who receives healthcare services at your organization and the prescription from your organization, and you being the eligible 340B covered entity. An eligible drug. There are a ton of eligible 340B drugs out there. There are, I think, under most wholesalers, there are about 16,000 plus drugs that are available through the program. Really, the biggest drugs that are not going to be available through this program are going to be limited distribution type medications, or in a lot of cases, orphan drugs as well are not eligible through this type of program. But generally, there is a ton of things available to your patients, a lot of potential for benefit. This goes to the 340B eligibility process flow chart. I'm not going to get too much into the weeds here because it gets really complicated and convoluted, but really this is just a picture to kind of help illustrate that when you're looking at a contract pharmacy, somebody to dispense medications at that 340B rate on your behalf, you need to make sure that that contract pharmacy has a way of identifying the patient as an eligible patient. At Walgreens, what we do is we identify 5 different criteria for a patient before we process them as a 340B for you, a 340B patient for you, and that's making sure that the patient was seen at your entity by a contracted provider or an employee of the facility who's writing the script. Is the provider performing service on behalf of the covered entity? Did the prescription go through a contracted pharmacy location? Is the medication itself under the price file? Is it a covered drug under the 340B program? Was it under an insurance plan that is covered through the 340B program? Otherwise, not a Medicaid type program or something like that. So this is our process, Walgreens' process. I'm not saying every contract pharmacy needs a process like this, but or exactly like this. But my recommendation would be to make sure that whatever contract pharmacy you choose to work with has a way to strictly identify the patients as being 340B eligible, and they have a great method of doing that. So make sure you're asking those questions when you're looking into a contract pharmacy partner to work with your 340B patients and your 340B scripts. Next. Sorry, there's a couple of animations here I'm getting through. Okay, next, uninsured claim versus an insured claim. So, the uninsured patient, and there's also a place for the 340B program with your insured patient. So the uninsured patient, really how they benefit from the 340B program is they're going to receive that lower cost of the drug. So, for example, if I'm an uninsured patient coming into your entity, and I'm processed and found eligible through the 340B program, then what I'm going to benefit from is instead of paying what I normally pay out of pocket, the cost of the drug, I'm paying now this 340B cost of the drug. And if you're working with a contract pharmacy, it's the cost of the 340B drug plus whatever fees the contract pharmacy has in place. So if I give you an example, that drug Levemir that I mentioned earlier, normally it's $200 out of pocket for the patient. If I'm an uninsured patient processed through the 340B program, that cost of that drug is now a penny, and I'll pay a penny plus whatever fees that the contract pharmacy has in place, usually somewhere in the realm of $10 to $20, somewhere in that range. So I'm paying now $10 to $20 out of pocket instead of over $200 if I'm an uninsured patient. So it can be really significant for the uninsured patient. For the insured patient, that's really where the entity sees the benefit. So through that insured program, the way that the entity earns money through the insured patient is, if I'm, again, the same example, I'm an insured patient now coming into your facility, the way I receive benefit is if I take my script, I pay my normal copay that I normally pay, and then the contract pharmacy would then take that full insurance claim that they received from the insurance company plus the copay, and they would take out whatever fees they have in place, of course. You, the covered entity, would be responsible for paying the 340B cost of the medication, and then the entity nets the remainder of that insurance claim. So you would then receive that net amount, and what Walgreens likes to call those dollars is increased access dollars, not revenue. We try to stay away from that word because it's a dirty word in any sort of nonprofit world, but you receive those increased access dollars through the insured patient. So with any 340B program, it's important to have a good mix of insured and uninsured patients, but the insured patients are the ones that the facility is receiving the benefit from. So this is just kind of goes into why Walgreens is a pharmacy. This is something that I don't really want to get into the weeds with you all today. I have limited time here, but this just kind of goes into, description, benefits, and why Walgreens. Kenya, I don't know if you're going to be sending this out after the call, but if anybody wants to dig in more into Walgreens and using us as a contract pharmacy, you're welcome to give me a call after this or shoot me an email, and I'll either put you in contact with the right person, or we can have a conversation about how we might partner better with your facility if your patients are coming to us in the community. So, and then this is our last slide here. This is what I mentioned. My colleagues regionally who work with the 340B program. Here's everybody's region. I know we have folks from all over the U.S. So here's everybody's region, and here's everybody's contact information, which I understand is a little bit difficult to see. It's a little bit blurry, but pretty much it's always the first name dot last name at walgreens.com is everybody's email address at Walgreens. So my name is Blake Hartgraves, so it'd be blake.hartgraves at walgreens.com if you need to reach me. But I think that was about it. And then I guess we'll take questions at the end, right, Kenya?
That is correct. Yes, we will be taking questions at the end. We already have questions popping up in the box. Thank you so much. And also, I will be sharing this video. The webinar is being recorded, and it'll be available on our website, UCHAPS.org, within the next 24 hours. So the next person that we have, great. So the next person that we have today is Miss Megan Canon, prep coordinator from the Houston Health Department. Megan, you should have control of the screen, and you can start whenever you're ready.
You're on mute, Megan.
Thank you. Sorry, I'm like talking. Thank you. Well, what I was saying before, thank you, Kenya and UCHAPS, for inviting me to speak on this webinar. My presentation will mostly focus on the plans that we're currently working on with expanding our 340B program to include PrEP. So as a full disclaimer, it's not something that we fully implemented yet, but my hope is to share the lessons learned of what we've learned so far so that you can avoid kind of some of the pitfalls or challenges that we've encountered in the process, and hopefully that's helpful for you all. So to give you, and I know this slide looks a little bit funky, but basically I want to give background to the health services that we provide from the Houston Health Department. So we have about 5 health centers across the city and county, and we offer a variety of services, which include family planning, STD, tuberculosis, dental, immunizations, and collectively we have over 52,000 encounters every single year of people who come in seeking service. The majority of our clients are self-pay, so we offer our services on a sliding scale fee, and a handful of our clients do have Medicaid, so it's about less than 10%, and we currently do not have any managed care contracts, so we don't have any contracts with any third-party private health insurance companies, so the majority of our payer sources comes from self-pay. We are already considered a covered entity through our family planning clinic because we do receive Title X funds that qualify us for that, and that program is very developed. And the focus of my talk is mainly to talk about how we're trying to expand it for the PrEP clinic that we just launched within the past year. And so we do receive funds from the state that qualify us under our STD clinic to become a covered entity for that aspect, to be able to provide PrEP under this program. And so to even take it a step back, we first launched our PrEP clinic, which you'll see the 2 stars on the slide. Those are our 2 locations where we're currently offering PrEP. We offer it 2 days a week, one day at each of those sites. And when we were looking at trying to figure out how do we make this clinic sustainable, because it's not very often that you get to start a new service line. So when we were talking with other PrEP clinics from across the country that have opened at health departments and even other CBOs, the thing that we constantly heard feedback on is you need a 340B program, you need a 340B program, you need a 340B program. So this process has been kind of a year in the making. So hopefully this will make sense as I explain kind of our process and what we've gone through. So when we were trying to figure out how do we implement 340B for our health centers that are offering PrEP, we had to figure out, since we already had an existing 340B program with our family planning clinics, were we allowed to use that existing 340B ID for our PrEP clinic? And the short answer is no, and part of the reason why is with each of the covered entities, if you're considered a covered entity, you're a covered entity for a specific service. And so for all of our clients who come in through our family planning clinic, they're obviously coming in for reproductive or contraceptive services. And since we knew that with our PrEP clinic, people could be coming in for family planning services, but for the most part, they're coming in to prevent HIV. And so when we were looking at the definitions of who would be an eligible patient under family planning, it didn't meet the mark. And so that's when we started going down the route of establishing a new 340B ID under our STD clinic, if that makes sense. And so it wasn't something that we had previously before, partially because a lot of the STD the medications that we offer in our STD clinics already are provided to us by the state, so that's not eligible under 340B. So this is something new for us with kind of going down this path. And so we applied for our 340B ID under our STD program back in April of 2017. And one of the things that we've learned is when you register yourself under a new 340B ID, there's a waiting period before that ID becomes activated for you to be able to use it. So even though we applied in April, the registration periods are available the beginning of every quarter. And so when we applied in the beginning of April, we weren't allowed to use it until July. So that was one thing that we learned through the process. And then in trying to figure out, what kind of delivery model did we want to use with our 340B program? So in terms of dispensing medication, so did we want to do that in-house? Because we do have that capacity. We do have pharmacy in-house that dispenses, acyclovir, TB medications, all that stuff. Did we want to go the contract pharmacy route, which I know Blake explained a lot in depth about that model? And then did we also want to do clinic administered settings? So like, did we want to have our providers dispense the medication themselves in the clinic while the client was there? There are pros and cons to each. I won't go over all of, it was a very lengthy process. Part of our challenge, I think, at our health department, which might not be the same case for everyone else, is because since we don't have managed care contracts, or we don't have relationships with private health insurance companies, it didn't really make sense for us to take the 340B program with dispensing the medication in-house, because like Blake mentioned, when we're looking at purchasing the medication for our insured and uninsured clients, both clients would be at a loss if we were to dispense it ourselves, because we wouldn't have an insurance company. You wouldn't be able to pay your copay if you were a privately insured client, because we don't have that relationship with, say, like a Cigna or like a Kaiser Permanente. And so because of that, and because we did want to see some benefit, we were interested in getting the increased access dollars that Blake mentioned. We decided that we wanted to go through the contract pharmacy route, because we felt that was a really big opportunity for us to be able to make sure that our PrEP clinic was sustainable moving forward. And so one of the things, and I'll move over, one of the things that also led, that we considered in our planning process was figuring out, okay, when we do start our 340B program for our PrEP clinic, who are the clients that we want to access this program? And this is specific to PrEP, so it might be different for, HIV treatment and for other services. But so that's the other disclaimer for this chart, and then the next slide. But we felt really strongly that because we were interested in, because 340B is a drug discount program, for an uninsured PrEP client, there's really not a lot of benefit for them in paying that, in accessing that program. And so I'll explain that in a sec. So if we're following through on this chart, so the uninsured PrEP client comes into our clinic, they're seen for their medical appointment, they talk with our PrEP navigator, and then the navigator helps figure out, what benefits are they eligible for. So most likely, if they're uninsured, and this is the case that we found in our PrEP clinic, most of our uninsured clients do qualify for Gilead's Medication Assistance Program card, which allows them to receive the medication for free. And so they would then go through the Gilead Medication Assistance Program system and fill the prescription at the pharmacy of choice. Because they're going down that route, they would not access the 340B program. If for whatever reason that client didn't qualify for the Gilead Medication Assistance Program because they made too much income to qualify for Gilead's program, we still would, this is the part where we're still in progress of trying to figure out what to do in that scenario. But my personal inclination is that we still wouldn't send them down to the 340B route. We would figure out another source to pay for that medication, because even though 340B allows covered entities, to say me as the health department, to purchase medication at a discount, if I'm uninsured and I'm going to purchase that medication, I'm responsible for paying whatever cost the health department paid for that medication. So even though Gilead at retail price costs like $1,800 per month, through 340B, that cost still is pretty high. I mean, personally to me, at like $800. So I don't know about you, but I wouldn't pay $800 a month for a supply of medication, and I don't imagine a lot of our clients would either. So for us, we know that we wouldn't send our uninsured PrEP clients down the 340B route. When we're looking at insured PrEP clients, similar process. So so in terms of navigating through, so they would come in for a medical appointment, they would see the PrEP navigator. Again, the PrEP navigator would walk through to see what assistance programs that they qualify for. If they're privately insured, for the most part, Gilead will cover up to $4,800 of their medication copay assistance if they're privately insured. So that what that means is that the client pretty much pays little to nothing for when they go to fill their medication. When they fill their medication at the pharmacy of choice, the beauty or one of the advantages of going through the contract pharmacy model is that Walgreens or CVS or whatever other contract pharmacy, they do have those relationships with those private health insurance companies that we don't have. So when the patient goes to fill that to fill their medication at that pharmacy, the contract pharmacy then is able to go back to that payer, so that health insurance company, to be like, hey, we dispensed this medication to your client, we're seeking reimbursement, and I'll go through in the next slide, but on how the whole process goes through. But basically, this is to show that our plan is to send our insured PrEP clients through the 340B program and not our uninsured clients. And this is a very complicated, it was nicer before, but what this shows is that, so for the insured PrEP clients that go through, this is a schematic, and I know it's a little bit complicated, so bear with me as I try to go through all the different pieces. So if they're starting from the health department, they receive the service, they go to the contract pharmacy, they get the medication, the contract pharmacy then sends the claim out, gets the reimbursement, and then from the privately insured health insurance company, that reimbursement then is given back to the health department because that's their money to begin with, because they sent the client over to the contract pharmacy. And because the other piece of the puzzle that we didn't realize, or that we're realizing more plays an important part, is we have to resupply that medication back. So, not only are we sending clients the drug that the clients are dispensed, we have to replenish that stock. So as the medication leaves the shelf, we would then, whoever our drug vendor is, or the wholesaler distributor, would send us a bill, because the contract pharmacy would send them a bill being like, hey, some drug left my shelf. The wholesaler would then send a bill to the health department, and then they would ship and replace the stock as when we paid the bill. So I know that was really complicated, but one of the things that we've learned in this process is that there are many different pieces that are involved in terms of the contracts that need to be in place, all the negotiations that need to happen amongst all these three parties if you do decide to go through a contract pharmacy model. Obviously, if you have the capacity to take it in-house, it's not as complicated, but doesn't lessen the need for auditing and monitoring and reporting and all that fun stuff. And so one of the things that we learned actually last week that we weren't aware of is, because we haven't purchased the medication yet, but we learned that Apexis, which if you aren't familiar with that resource, I highly recommend you check it out, and I'll write it in the chat box so that everyone can access it. But Apexis is a resource that's available through HRSA, and they are a wealth of knowledge around all of this process, and they have lots of different webinars, and they let us know actually that for people who are interested in purchasing drugs through 340B, there's a 340B Prime Vendor Program, which is a separate registration from the 340B ID that you apply through HRSA, but that program allows you to get access to better prices for medication because they basically have this whole network of wholesalers and manufacturers that they work with. So instead of me coming in as like this small but large health department, you're able to come in with a network of other 340B covered entities to hopefully get the best price for your program. So I know I talked a lot and I talked really fast, but hopefully with all the stuff that I shared, you found it helpful. And then Kenya, I'll give it back to you. Oh, and here's my contact information if you want to touch base.
Yes, thank you so much. I just want to remind everyone, if you have questions, please feel free to enter them into the Q&A box, or if you want, you can put them in the chat box. And we'll be getting to those at the end of the webinar for all the presentations. So if you aren't aware, there are some potential changes being made to the 340B pricing program. So today we have Kahlib, Barton, and DC Mobilizer from the AIDS Healthcare Foundation to talk about some actionable steps to help protect 340B in your area. So Kahlib, whenever you're ready.
Thank you. So, hello everyone. Again, thank you, Kenya, for having me. Thank you, UCHAPS, for hosting this conversation. So I'm here to talk to you about the policy issue of 340B. So I want to set the tone a little bit, and then I'm going to go straight into what we all can do personally, individually, and our organizations to be able to get behind 340B to protect this very, very amazing program. So as April mentioned, 340B is a program that benefits folks who may be a little bit more underinsured to be able to access medication that they need. So the way that it works, as has been already discussed, is that the entity is able to purchase the medication at a much lower rate, and then they are still able to charge the insurance company the full amount, and then that remaining amount of money goes straight into into making sure that the entities are able to provide their clients with services such as, for a lot of our agencies, free HIV testing, being able to access adherence counseling, being able to access any type of food pantries, those type of things. So the wraparound services that really make sure that our clients have a better quality of life are usually covered in that money that entities are getting back from the 340B program. So currently, the 340B program only accounts for about 2.8% of all drug purchases. However, Big Pharma is not necessarily in favor of this program lately more than anything, because it is seeming to expand. Ever since the expansion of Medicaid happened and the passing of ACA, in some states and some entities, a lot more safety net providers are eligible now to be able to receive 340B funding. So this program that's been around for about 25 plus years is now really, really on the radar for Big Pharma. And it's because, you know, that 2.8% of all drug purchases is probably kind of doubled, and they can only see that increasing. But you know, I guess there is to them some harm in making sure that our clients have everything that they need to have very successful and healthy lives. Nonetheless, what we can do individually is basically have the mentality that it's not broke, so we don't need to fix it. And any type of harm, any type of changes that are made to potentially made to 340B is going to be a lose for us. The reason why it's very important for us to get ahead of this, as Big Pharma tries to chip away at the 340B program, is because if they are successful in drawing back on the amount of safety net providers that can access 340B funding, then eventually in the future they may try to do away with the program altogether. And especially considering the climate of things right now, it's very important that we be proactive to make sure that we protect this program. Of course, it's very important to note at this point that this is something that does not cost taxpayers a dime. It costs taxpayers nothing. It is something that benefits taxpayers more than anything, and it's no additional cost to them. What's happening is you have HRSA that provides oversight, monitoring, and regular audits for safety net providers who are eligible for 340B funding, to ensure that that funding is being used to benefit the overhead, the cost of free HIV testing, again, the cost of wraparound services, those additional things that we can use to benefit clients that typically don't come at a cost to them. So the way that you can help individually, the most effective way, of course, is to get involved by contacting your congressperson or representative. It's really, really important that you do this the old-fashioned style, which is a handwritten letter. It is the best way to get your congressperson's attention. If you do not know who your congressperson or representative is, there are a number of ways you can do this. excuse me, one of the best ways, of course, is to go to house.gov, and you can simply enter in your zip code or address, and then it will tell you who your representatives are, Senate, House representatives, everything. But another thing that is a little bit more of a tech savvy millennial thing that people can access, to all those folks who are Facebook users, Facebook actually has an option now. So if you click on the three-line icon whenever you're on your Facebook page, it usually will take you to like your profile, and it'll have like a lot of different options there of like events and any groups that you're a part of. And if you scroll down, you'll see an option that says Town Hall. If you click on that town hall, you can enter that information about where exactly you are, and it will give you from there who your representatives are, and you can like their pages and also contact them that way. But of course, again, the most effective way to get in contact with your congressperson or representative is by a handwritten letter. This is something that has been proven. Congress folks have said that they do read the letters, and that there is some impact that happens from this. So when writing your letter, it's very standard. You want to make sure that you start out with a very standard greeting, and then make sure that you address them as the Honorable such and such. So in the body of your letter, you want to make sure that you open with a greeting, and the initial thing you want to do is start by thanking that congressperson or representative for something that they did recently, if you are aware of what that is, if it impressed you. If your congressperson or representative is not someone that you fancy, it is very good to just generally thank them for their service and keep moving forward by letting them know exactly what you need. Of course, in the body of your letter, you want to include information about exactly what it is that you want. So get straight to the program, to the point of letting them know that you're writing to defend 340B drug pricing and why it's important to you. It is always important to make sure that you include some personal notes. So maybe a little bit of information about where you work, where you live, how this program may have benefited you, if you're comfortable with sharing that information. Some very good, very short tips. Keep your letter very short. Never do over a page. Make sure that you mention safety net providers in here, especially if you are someone who works for a safety net provider, or if you have been in contact or benefit from a safety net provider. Telling a personal story is always helpful. Be kind and include any type of local references in your letter. Most of all, you want to be sure that you tell them exactly what you want, what you really, really want, as the Spice Girls would say. Make sure that they know to protect 340B, let it be as it is. Again, it is important to note that any type of chip away at the 340B program as it stands is potentially harmful to the program overall. If Big Pharma is successful in drawing back on the amount of safety net providers that can access this program, then they'll eventually will be moving forward to try to do away with 340B programs as it stands. Again, this program only accounts for about 2.8% of drug pricings regularly, and now that has slightly increased, but no more than about 4%. So it's important that we continue to protect this program, and if anything, we want to increase the amount of protections our clients have and access that they have, and not draw back on that. So we hope that you will be steadfast and active in making sure that you kind of let your clients know, let your people know, your colleagues, that it is important to get involved in this political process of protecting 340B, to make sure that we all can continue to serve our clients in the same way, and that we all are able to continue to improve and expand their access. If you would like to receive more information about this program, please go to let340b.org, and it will give you a lot more information. There's a very cute, like 3-minute video that you can use, and you can also take that video and share it with your clients or your colleagues, send it to them in an email, whatever. It explains the program in depth about exactly how the mechanics work, and of course that it costs taxpayers nothing, and that and how it benefits folks. Thank you.
Thank you so much, Kahlib. So now we're getting to the good part. Now we're ready for the Q&A. What I'm going to do is, again, if you want to post your question in the Q&A box or in the chat box, you may. Or if you'd like to speak live, to one of our experts, you can do the raise your hand feature, and I will unmute your line so you can get a chance to ask your question live. We do have a few questions in queue. So the first question is, and this is open to any one of our panelists, if you are a subcontractor of a Ryan White funded agency, can you apply for 340B pricing?
Yeah, so I can try to help answer that, Kenya. So my recommendation for if you're trying to discover if you're eligible for 340B or not would be to contact Apexis. And Megan actually put it in the chat a little while ago, apexis.com. They have a really quick question and answer forum that you can use called Apexis Answers. They have a phone number, an email address, or even a direct chat for your computer for any of those types of questions that you want to ask. So that's who I would reach out to if you're asking about specific to your organization, how you become eligible and how you register for the program. They'll walk you through everything step by step.
Awesome, thank you so much. So let's see, we have another, we have two more questions. Question actually for Megan in particular, to put your name in. What is your plan for uninsured patients who do not qualify or make too much income for Gilead's Medication Assistance Program card?
That is a great question. And I forgot to mention this when I was talking, but with the uninsured patients, because if they don't qualify for the Gilead Medication Assistance Program, and obviously like if they're uninsured, most likely will not be able to pay the retail price or even the 340B price. The hope is if we have enough insured PrEP clients who come in and access the 340B program through a contract pharmacy, we would get enough increased access dollars to then share those savings to the uninsured clients. So whatever reimbursement that we would receive from our insured PrEP clients from dispensing the medication at that contract pharmacy, if that makes sense, whatever reimbursement we receive, we're allowed to do whatever we want with those increased access dollars. And my hope is that we would be able to pass the cost on to help pay for the people who fit in that scenario where they're uninsured and don't qualify for other assistance programs to get the medication down at a level that they're able to pay.
Yeah, and Megan, my additional suggestion on that is to make sure you're reaching out to your pharmacist. Whatever pharmacy that the patient is going to, if they need help with their medications, there's a ton of foundations and funds and things out there made to help patients who fall within that particular type of donut hole. So just make sure you're reaching out to your pharmacy and utilizing their expertise. So that's my only other suggestion on that one.
Awesome, thank you. Okay, so I have four more questions. First question is for Houston. Can the presenter from Houston explain how organizations can join the big 340B consortium? This is Amy Nunn, Director of Rhode Island Public Health Institute.
And thank you, Amy, for the question. When you say 340B consortium, are you referencing the 340B price, the prime vendor program that I was talking about before? If that's the case, because I'm also seeing Nikki's comment in the Q&A chat box too, if you're asking about that, the 340B prime vendor program, you apply through that through Apexis. So I can write the website again, and you register to become part of that prime vendor program, which then gives you access to seeing like what pricing and what products are available through 340B that you can access if you're a covered entity.
Awesome. All right, so you answered the question for Nikki also. Sure, Amy, I'll do that for you in a few seconds. Can you mention a few more of the ways in which a clinic or 340B entity could use the savings from the program?
So for us, and this is where, you know, we're figuring it out too. So I think since currently the 340B program doesn't restrict how you spend those, if the covered entity does receive benefits with increased access dollars through participating in 340B, there's no rule or stipulation on how you use those access dollars. The hope is that you would then pass it along to increase access for your clients as a safety net provider. So again, that's up to each organization with figuring out how they want to do that. For us, with our PrEP clinic, we hope to pass along those dollars to help pay for medication for our uninsured clients and, you know, other PrEP-related things that they might not be able to pay for with the under the sliding scale fee. But again, that's not a hard or fast rule for every organization. I think that's up to each individual one.
Right. Yeah. And just kind of dovetailing on what you said, Megan, that HRSA has very, very gray wording around what those increased access dollars need to be used for. So as Megan mentioned, the hope is that you're using them to increase access to your patients, but how you define that is kind of up to you and your organization on what's going to benefit your patients the most. So.
Okay, awesome, thank you. I have another follow-up for Megan. How do we pass along 340B benefits to patients after they meet the $4,800 deductible from Gilead Patient Assistance Program?
I think that one's probably related to the other question that we just answered too. So again, it's up to, I think, you know, that's something that we can consider too. Our PrEP clinic hasn't been open very long, so I have to double check to see if any of our PrEP clients have already met the copay assistance program that Gilead offers, and if they're footing a really large bill for their medications. I think the hope and intent that once we do implement our 340B program, that whatever increased access dollars or cost savings that we accrue from having our insured clients go through this, getting their medications at a 340B contract pharmacy, that we would then use that to help increase access for obviously our uninsured, but then also insured if they need support too.
Awesome, thank you. I have a live question from Amy Nunn. I'm going to unmute her line right now. Amy, can you hear us? Amy? Unfortunately, it seems like she's. Are you there, Amy? No.
No.
Okay. Okay. Amy, if you still have more questions, please enter them in the Q&A box, and I'll be happy to answer questions. Nikkei Blue from Houston said, I believe the Gilead deductible has increased as of this year and now should cover uninsured for the full year. So that's a little update for you. If you've raised your hand and I didn't get to you, please send me a note so I can unmute your line. We still have a question if the question hasn't been answered. Or any additional questions you may have. No questions? Okay. If at any time you think later on that there might be a few questions you want to ask, feel free to send me an email, and I will be happy to pass a question along to get the answer from one of our experts. What I'm going to ask everyone to do is to please take a moment and complete the survey, a 30-second survey, just to tell us about your thoughts on today's webinar, if it's beneficial or not. I'll also be sharing this in the chat box for you to do. It's only 30 seconds, only about 3 questions. Then it will really help us move further. Oh, wait a minute. Okay. You're welcome, Amy. Amy said this is extremely helpful. And thanks a million. And yes, I will be posting all the speakers' information as well as it will be live on our website tomorrow recording. So there goes my contact information. If you have any further questions, please feel free to contact me. There goes my email address and my phone number. And I'll be sure to funnel your question to the expert that you'd like to speak with, and get you an answer right away. 1 second, I'm going to post our link in the chat box so everyone can answer it. Thank you, Blake and Megan for sharing the information. Kahlib, do you want to share your information as well in the chat box? Thank you so much. And here goes the link to the survey. Again, it'll only take 30 seconds to do, and it'll really help us a lot. A follow-up email will be sent out tomorrow to everyone that joined us with a link to answer any questions, to review the webinar, I'm sorry. And if there's no questions, thank you so much to our panelists. You guys gave a wonderful presentation. Like, questions are popping up. Everyone seems engaged. Thank you again. And thank you everyone for joining us. Have a good day.
Thank you.
Thank you.
Thank you, everyone. Bye-bye.